Assalamu alaikum warahmatullahi wabarakatuh. A very good evening to all the doctors, nurses, and our friends from pharmacies who have come online for today's webinar entitled Pediatric UTI Update, organized by Dubai Pediatric Club in affiliation with NMC Specialty Hospital Dubai and Vitabiotics New Country Healthcare. Myself, Tawfiq Ali, Country Business Manager of Vitabiotics. As many of you have already attended our previous webinars, this is the continuation of DPC and New Country Healthcare Affiliation webinar series. Inshallah, our next webinar will be on 3rd of November on rickets and vitamin D3. To proceed further, I would like to invite Dr. Sohrab to take over the program. Dr. Sohrab Tamarai is a very well-known personality in UAE who doesn't need any introduction here, but he has told me not to say much about him today, and hence I am restricting myself introducing him. Dr. Sohrab is the president of DPC and working as a senior specialty pediatrician at NMC Specialty Hospital, Dubai. That's it. So, Dr. Sohrab, web is yours. You can take over the program, Doctor.
Well, good evening, ladies and gentlemen. On behalf of the members of Dubai Pediatric Club and the organizing committee, I would like to welcome all of you to this webinar from Dubai, UAE, GCC countries, and other countries around the world. Today, we had surprisingly 2,400 some registration. I'll be sharing with you my slides. Well, am I audible? Is it seen?
Yes.
Can I continue?
Yes, please.
This webinar is semi-accredited in collaboration with the NMC Specialty Hospital. I would like to thank Dr. Vamsha Shetty, the head of CME program. This webinar is also hosted by Vitabiotics. I would like to thank the country manager, Mr. Tawfiq Ali from Vitabiotics. It's a very interesting. I found something about history of Vitabiotics in a short while. I'll discuss with you today. Our topic is UTI and complication, which will be discussed by Dr. Kalpana Sengupta. I will give a very brief account of the history of UTI. Beautiful city of Dubai. Those who have not seen, please come and see. This is the best time of the year to come and see Dubai. Well, the members of Dubai Pediatric Club and the members of the organizing committee, on behalf of all of them, I would like to welcome the viewers as well. Today, we have a panel. Our speaker is Dr. Kalpana Sengupta, Senior Specialist Pediatrician, NMC Specialty Hospital, Dubai. She is Secretary of Dubai Pediatric Club. Now, please join me in congratulating her as head of Department of Pediatrics in NMC Specialty Hospital, new head of the department. We have also with us Dr. Diari, consultant pediatric surgeon from Latifa Hospital, well known to all, and Dr. Ayman Jundi, senior pediatric surgeon from King's Hospital. They are in our panel. Also, we have Dr. Joshi. He will be joining us shortly. He will moderate the session. Dr. Joshi was the past president of Dubai Pediatric Club and the senior specialist pediatrician in Prime Group. Well, these are our pediatric surgeon, always together. Well, I said pediatric surgery. I would just like to give a brief history of pediatric surgery. William Latz is the father of pediatric surgery. Nearly 100 years ago, Dr. William Latz from Boston Children's Hospital helped to establish pediatric surgery. The recognition that children require unique surgical management hasn't changed, but instrument and procedure we use to operate children have evolved dramatically. Well, this is Dr. Latz, and these are the instruments from ancient till today. Well, this is very interesting about pediatric surgery. The 1920 marks the earliest use of the scrub. Interestingly, white gowns, white masks, and white linen emphasized the importance of cleanliness and perhaps compensated for the dim lighting. Chloroform and ether used as anesthesia, and though penicillin was discovered in 1928, antibiotics were still decades away from the actual use. Imaging was only X-ray. It was in this setting that pediatric surgery began to evolve. See, with nothing, they started. Well, we have our 6th annual webinar, virtual conference. It was supposed to be in the hotel, but to protect our members and distinguished faculty members, the organizing committee decided to do it as a virtual conference on 20th November. It will be in a big way. Well, they are the faculty members. We have the dermatologist, Dr. Khan, radiology, Dr. Vikram, very eminent panel in gastroenterology, hepatology. We have Dr. Ajmal, Dr. Mirdadi, Dr. Tomar, Dr. Venkat. In infectious group, we have Dr. Krishnamurthy, Dr. Aswaidi, Dr. Walid, and Dr. Anjan. Pediatric surgery, very well known, Dr. Diari, Dr. Ayman Jundi, Dr. Hussein Naji, and Dr. Nadim. Neonatology, Dr. Monica Koshal, Dr. Zahiruddin, Dr. Nishad, and Dr. Arif Fari. In neurology, we have Dr. Aman, Dr. Vivek, Dr. Arif Khan, and Dr. Makki. And of course, quiz, Dr. Diari, surgical quiz, and Dr. Kalpana, a medical quiz with our chairperson. Well, is Mr. Tawfiq Ali, the country manager of the Vitabiotics. I would like to just say an interesting point about the Vitabiotics. Actually, this company was founded in 1971 by Mr. Khartar Lalwani. His son is now the CEO. Please concentrate on the last para. Vitabiotic became the first vitamin company in history to receive the Queen's Award for Innovation for the 3rd time. It was very interesting for me also to find that to get 3 times Queen Award is really amazing. Well, today I'm going to talk about the history of the urinary tract infection. See this portrait, they talk to us. No need to, write text for that. In those days, 6,000 years ago, physician, patient, and urine chart. They used to diagnose the patient. Very interesting. Well, I always start my talk in the memory of Hippocrates, the father of medicine. Well, the beautiful painting from 17th century, but this is alchemist. It's showing beautiful portrait showing the physician, patient, and urine sample. Well, urinary tract infection have been described since ancient times, with the first documented description in Eber's papyrus, dated 1500 BC. It was described by Egyptian as sending forth heat from the body, from the bladder. Effective treatment did not occur until the development of and availability of the antibiotics in 1930s. Before that time, herbs, bloodletting, and rest were recommended. Of course, apart from bloodletting, others are now also recommended. You see the beautiful paintings there. And about this, Eber's papyrus, also known as Papyrus Eber's, is Egyptian medical papyrus of herbal knowledge, like an encyclopedia of the herbal, dating to 1050 BC. Among the oldest and most important medical papyri of ancient Egypt, it was purchased at Luxor in 1873 by Georg or George Eber. Now it is currently kept in the University of Leipzig in Germany. And these are the herbal and non-herbal medication used to treat the UTI. Well, as I said, laboratory medicine began 6,000 years ago with analysis of human urine which was called uroscopy till 17th century. And today it is called urine analysis. Of course, Dr. Kalpana will mention about this. Physicians spoke of urine as a divine fluid or window to the body. Babylonian and Egyptian physicians began the art of the uroscopy, even before Hippocrates. Uroscopy, from the word uroscopia, means the scientific examination of urine. The word is derived from the Greek word uron, meaning the urine, and scopia means to examine. Although Hippocrates is credited for that, uroscopy, but the urine diagnosis is believed to be predated. Well, this is interesting. Since today, physicians use urine to diagnose selective condition, but from ancient time until the Victorian era, urine was used as a primary diagnostic tool. Uroscopy was mirror of medicine for 1,000 years, from liquid window through which the physician felt they could view the body's inner workings. Now, this is very beautiful in the center. You see, this is called uroscopic wheel. Now we have a dipstick, urostic. Dr. Kalpana will be talking about 6,000 years back. They had this chart. The doctor used to examine patient, take the urine sample and compare it with the chart and diagnose and treat. See patient in front of the physician and the chart. Now, numerous somewhat accurate physiologic theories arose from this uroscopy. Then it's a uroscopy escaped medical control and becoming first a home health aid and then a tool for uneducated practitioners. It is really true. Now, the patient goes and gives the urine to the lab and gets a report and come and show to the doctor. 6,000 years back, the patient in front of the doctor. Doctor used to examine, take the urine, see, diagnose. See, beautiful painting. It speaks by itself from ancient times. Of course, midstream urine was always recommended, as you see here. But as I said, Sumerian and Babylonian physicians 4000 BC recorded their assessment of urine in clay tablets. Ancient Sumer also described urine characteristic in different diseases. Now, this part is important. In Sanskrit medical was also in 100 BC, 20 different types reported. Now, this part I want to emphasize. Hindu culture were aware that some people urine tasted sweet and that black ants were attracted to this sweet urine, a characteristic of disease now known as diabetes mellitus. In those days, they used to ask the patient to stand past urine. Where ants were there, that patient had diabetes mellitus. The word diabetic comes from the Greek, means to siphon through. Diabetes means to siphon, mellitus means honey. They thought that they are passing honey from the urine. And this was coined by Artius in 2nd century. Of course, Artius described in a poetic manner as a melting down of flesh and leave into the urine. Really beautiful. I want to show hundreds of this and watch this beautifully depict physician, the patient, and the book, chart, and the wheel. Well, in the Hippocratic era, the predominant theory of disease condition was 4 humors. These were blood, phlegm, yellow bile, and black bile. Then Hippocrates hypothesized that urine was a filtrate of these humors. And in his aphorisma is like principles of medicine, Harrison principles of medicine. That time it was aphorisma. Hippocrates described bubble, owing to the proteinuria that lay on the surface of the urine, indicating long-term kidney disease. And Hippocrates also associated urinary sediment with fever and noted that sediment increased when fever worsened. See what an observation they have. And the presence of blood in the urine showed that bladder ulceration. Now, I'm going to finish by 1 or 2 slides. This is a very beautiful timeline for kidney starting from 1550 BC. green one is anatomy, blue is physiology, and red is clinics. As you see, in 400 BC, Hippocrates described anatomy, Galen described the filtering of the urine. It went on like this. Avicenna described in his book, Qanun, Malpighi. Then I'm not going to do that. See, from the beginning till end, historically it has come. And these are the instruments they used in ancient ages. Well, something about dialysis to remember: pioneers Bright, Graham, Abel, and Korf. They did a lot of work in this. We have to remember them. Well, a beautiful painting of uroscopy. I would like to end by a quotation from Hippocrates. Says, science is the father of knowledge, but opinion breeds ignorance. Nowadays, everybody gives opinion without any scientific basis. Well, with this, now I would like to introduce our speaker, Dr. Kalpana. She is well known to everybody, at least in Dubai, UAE. Dr. Kalpana completed the MD Pediatrics from Bombay University, DMB from National Board, DCH from the CPS Bombay, and MRCPCH from UK. She has been an outstanding student with many awards and gold medals at the university level. She has more than 26 years of experience in pediatric, and a special area of interest are pediatric nephrology and intensive care. She has done a lot of work in nephrology, and in fact, she was once head of nephrology unit in one of the Bombay hospitals. Dr. Kalpana was an associate professor of pediatrics at BJW Wadia Hospital for Children, BJWAC it is called, and a lecturer at LTM Medical College, Bombay. She was also a research fellow in pediatric hematology oncology department in Bombay. She has many publications in Indian and international journal, and currently she is a senior specialist pediatrician and head of department of pediatrics at NMC Specialty of Dubai. She is the secretary of the Dubai Pediatric Club. With that, I end. I would like to once again invite you to Dubai, beautiful Atlantis. Now, I would like to request Dr. Kalpana to start the presentation. I would like to request the viewers to write the question in question and answer box. And after Dr. Kalpana finishes the talk, then question and answer session will start. At the end of this meeting, there will be a raffle draw with 3 very nice prizes. Thank you very much. Over to Dr. Kalpana.
Thank you, Dr. Saurabh, for this nice introduction. And I will share my slides now. Dear friends, we are all here today to revise a very important subject that all of us deal with in our day-to-day pediatric practice. This is a pediatric UTI update, and this talk has been divided into 3 sections as per Dr. Saurabh's request. I will first be touching upon the most important topic, that is the urine examination. Why do we need to discuss this topic of UTI? Because it accounts for more than 400,000 ED visits per year. OPD visits are increasing, though the admissions for UTI and its complications seem to be decreasing. In one of the recent studies published in 2019, it has been said that UTI accounts for the second most common cause of fever in those visiting ED emergency departments after viral infections. So coming to urine examination, just touching upon some of the basics before we can go to discussing UTI. Composition of urine is affected mainly by 3 factors. It depends on the nutritional status, state of metabolic processes, and the ability of the kidney to selectively handle the materials presented to it that lead to the various abnormalities that we may see. One of the most important and difficult part of assessing a case of UTI is urine collection. As we know, there are non-invasive methods and invasive methods that have been described. Non-invasive methods like the clean catch specimen collection and a midstream urine collection are time consuming and can be done in children who are toilet trained and are older children. Parental involvement is very important here. We have to spend some time in our busy emergencies and in our outpatient departments to explain to them to clean the local parts with soap and water, and then let the first few drops of urine be discarded, collect the midstream urine in the bottle given by the lab, and transport it to the lab as early as possible so that we avoid contamination at any cost. Invasive methods like catheterization and suprapubic aspirate collection, these are preferred in advanced countries like USA, though the day-to-day UTI cases that come to us, the acceptability of parents towards these methods may be questionable. So we have to pick and choose which method we are going to use. But what we are not going to use is a bag collection. Bag collection is not recommended for culture by any of the guidelines that we follow. So please don't attach a bag because it's the contamination rate is very high. Urine collection pads have been devised, and studies have shown that changing it every 30 minutes almost eliminated heavy mixed growth contamination. Now, please notice that this requires 2 to 3 people to be with the baby, change the urine collection pad every 30 minutes, and it says almost eliminated. So again, not a very good method. This is a pictorial demonstration of doing a suprapubic aspirate, which if done with USG guidance gives us a better idea. Coming to the urine examination, we all know that the color of the urine is decided by the urochrome, and this gives us an idea of the hydration status of the patient. It is altered by various food articles, drug consumption. One of the important, though rare, entity is blue diaper syndrome, which is where babies may come to you and parents may complain that there are blue stains seen on the diaper. This is due to tryptophan malabsorption. These children, this is a genetically inherited illness, and these children may also present with fever, other digestive abnormalities. They may have ophthalmic issues, optic disc hypoplasia, and they can go on to develop hypercalcemia and nephrolithiasis. Now, a similar condition is described in older adults called as purple urine bag syndrome. We'll come to that in a minute. The clarity of urine is affected by the cellular content, be it debris, cast, crystals, bacteria, or proteinuria. Now, this is the purple urine bag syndrome, can be very distressing and puzzling to the people who do not know about this condition, commonly seen in institutionalized adults, mainly females, who are constipated and who have UTI. This is due to bacteria in the urine, which have phosphatase and sulfatase enzymes, and it causes certain pigments in the urine, which give it this color, which is purple in color, and it has to be identified and treated accordingly. Now, just something to think about, that in our children who are chronically catheterized, those with neurological abnormalities, probably we would be encountering this once in a while. Moving over to the dipstick analysis, which is supposed to be a very quick and fast method. We look at the pH, which is generally acidic, though can change related to the diet. Importance of pH is in renal tubular acidosis and urolithiasis. Important to know response of treatment in rhabdomyolysis or drug overdose. Specific gravity is a rough estimate of urine osmolality and the hydration status. As we know, it is low in diabetes insipidus, sickle cell nephropathy, acute tubular necrosis, and high if there is presence of proteins or keto acids. Glucosuria, we are familiar with. Ketonuria. Please remember, it is not only in DKA. The commonest cause of ketonuria seen in pediatric practice is due to starvation or vomiting. Nitrite test and leukocyte estrase test. These are important tests for UTI. We'll be touching upon that in a minute. Urinary bilirubin is increased in excessive hemolysis, hepatic parenchymal diseases. But apart from that, even in constipation and intestinal bacterial overgrowth, we may see a bit of it. Decreased in obstructive jaundice and severe cholestasis. Proteinuria is very important, as all of us know, in the commonest condition that we deal with called nephrotic syndrome. Coming to the cellular contents, RBCs in urine may be indicative of hematuria, hemoglobinuria, or myoglobinuria. WBCs, though most often are neutrophils, in some cases of interstitial nephritis, we may see eosinophils, and tubular interstitial diseases may present with lymphocytes in urine. Epithelial cells, if they are more than 15 to 20 per high power field, are generally suggestive of contamination. Casts, hyaline casts could be non-specific. RBC casts are seen in glomerulonephritis and vasculitis. WBC casts in tubular interstitial nephritis, acute pyelonephritis, granular casts in acute tubular nephritis, and waxy and broad casts in ARF, fatty acid casts and lipiduria in nephrotic syndrome. So these are the various casts that we may see in so many conditions. Coming to the crystals, we all in MBBS learned the variety of crystals, the variety of shapes. We had to memorize this. And where do we see these? Calcium oxalate crystals in acute kidney injury and ethylene glycol ingestion. Uric acid crystals are important in tumor lysis syndrome and gout. Cysteine crystals in cystinuria. Struvite crystals in UTI caused by urea splitting organisms like Proteus and Klebsiella. They have a classic coffin lid appearance, and bacteria and yeast cells sometimes are reported. However, the fact to remember is, if you just look at these pictorial presentation of uric acid crystals, they are present in all sizes and shapes. And this, to my left, is a picture of uric acid crystals, and to the right of calcium oxalate monophosphate crystals. Now, they look very similar, dumbbell-shaped appearance. So as a general rule, the same substance can form many different crystals, and very similar crystals could be formed by entirely different compounds. So we should not read too much into it. Coming to the main topic of the day, UTI. Who needs evaluation for UTI? Children, those who present to us with localizing signs or suspected UTI. Obviously, older children, verbal children, more able to say, easily able to say it pains, there are urinary symptoms, there may be fever. However, children who present with fever, especially if they are neonates and infants, should be evaluated for UTI. Children with alternate sources of infections do not require urine analysis, except in cases of sepsis in infants, in those who have congenital anomalies of kidney urinary tract. Because if they are antenatally diagnosed,
Dr. Kalpana,
yes.
you are not changing the slides. It's only still as a general rule. The slides is not changed.
It's changed here for me, doctor. What about now? Is it seen now?
Yes, it is.
Yes.
Okay. So sepsis in infants, those with congenital anomalies of kidney urinary tract, because as I said, they have 19% risk of UTI before they reach 2 years of age. Those at risk for complications that we are expecting, say for example, somebody is born with a single kidney, or febrile illness which is not following the accepted clinical course. Coming to dipstick test, as I said, we would be touching upon it, upon the two important things, that is leukocyte esterase test. It's indicative of pyuria. Pyuria is 78% specific. However, a culture is advised before we treat these children. Nitrite test positivity is supposed to be more specific for UTI, but remember, it can be negative if non-nitrate reducing bacteria cause infection, and especially in infants if there is a rapid emptying of bladder. The microscopic examination can show us, like in this slide, multiple rod-shaped bacteria shown between the larger white cells at urinary microscopy. This has to be done in a fresh sample, and this has to be taken along with the leukocyte esterase, nitrite test, and the clinical picture of the baby. However, urine culture still remains the gold standard for diagnosing UTI. Diagnosis of UTI, clinical judgment is important. This is the most important statement, because we can have a lot of guidelines, a lot of differing guidelines from various international bodies. According to AAP, American Association, the between 2 to 24 months of age, more than 50,000 colony forming units per ml of a single organism growth in a catheterized sample with pyuria or bacteriuria positive nitrite test is taken as indicative of UTI. Canadian guidelines suggest that dipstick test can be more than 10 raised to 5 in midstream dipstick test positivity with more than 10 raised to 5 CFUs per ml in midstream urine, or more than 50,000 CFU per ml in catheterized sample, or any growth in suprapubic aspirate. The European Association of Urology and European Society of Pediatric Urologists have taken this down even further and said growth of 10,000 or even 1,000 CFU per ml of uropathogen from a catheterized sample or any growth from SPA is indicative of UTI. However, we do come across cases of sterile pyuria, though there are many causes like it could be TB, it could be allergic or chemical inflammation, Kawasaki crystalluria, appendicitis, other regional enteritis. The thing to remember in day-to-day is cervical or vaginal secretions. Please do not forget to examine genitals, especially in girls, and if they have vulvovaginitis, that might be giving them pyuria, and it may not be a true urinary tract infection. Asymptomatic bacteriuria is not to be treated. Urine culture is positive, but no clinical symptoms and signs, and pyuria, especially in girls and in those with underlying genitourinary anomalies. Now, I would like to mention here that quite often we are referred cases where the urine culture examination has been advised as a routine in those with underlying genitourinary anomalies, and the parents have a lot of anxiety associated with it. They come to us every month, every 3 months, saying somebody has advised them. So if you were to do a urine culture with no other background, clinical background, and it comes positive, it's asymptomatic bacteria, and you treat it, you will just go in a circle. This is not to be done, not recommended. So this has to be really targeted from patient to patient. So we have diagnosed now, well, how do we treat? Again, case-to-case basis is important. Certain general guidelines are important, like prompt treatment, especially in urosepsis. Whether we'll give oral or we'll give parenteral treatment. Now, obviously, those who can tolerate oral feeds, they are not toxic children, you will give oral medication. Parenteral, specifically, suppose there is a toxic infant or hemodynamically unstable child, immunocompromised child is unable to tolerate oral feeds or oral treatment, and the children not responding to oral treatment. These would be indication to give parenteral treatment. And obviously some of them would require inpatient treatment as well. Duration of treatment. A lot of studies have looked at whether a shorter duration of treatment is enough for children. However, till date, it has been the AAP guidelines state that 7 to 14 days of treatment is required. Resistant UTI due to ESBL, we will talk about it in a minute. Do not treat asymptomatic bacteriuria. In case of non-responders, please check the compliance, and if they are very compliant, rule out other complications like abscess formation, obstruction, fungal infections. Candida was thought to be cause for 50% of UTIs in PICUs, and if none of this is there, also look at non-urinary tract problems, which could be causing the confusion. Bacteremia along with UTI is quite often seen in neonates and infants, especially if they are premature. They may have azotemia at presentation. They may even present to you with febrile convulsions. So what are the risk factors for urosepsis? Age less than 2 years, congenital anomalies of kidney urinary tract, and immunosuppression. Example, transplants. Now, ICU admission is advised if hemodynamic instability is present in urosepsis. The treatment will be tailored depending on whether it's a community or a hospital-acquired infection. Is there presence of meningitis? It has been, various studies have proven that there could be up to 1% chance in, especially in neonates with UTI, to have associated meningitis as well as a part of sepsis. Whether there's a presence of acute kidney injury or it's an end-stage renal disease, and the nephrotoxicity of drugs has to be kept in mind. Now, more and more cases of extended spectrum beta-lactamase producing Enterobacteriaceae infection are causing UTI present to us, and CDC has been monitoring these, and there has been a 53% rise from 2012 to 2017 in these cases, and more so of late. There are a lot of antibiotic resistant cases that present to our OPDs. So this is a multi-drug resistant UTI. Earlier, these cases were thought to be hospital acquired, but there are a lot of cases of community acquired ESBLs. The two risk factors that have been associated with increased incidence or prevalence of ESBL are recent hospitalization and antibiotic use. Various organisms, E. coli, Enterobacter, Citrobacter could be causative. So when we do these cultures and we get the sensitivities to various antibiotics, they are resistant to the normally used cephalosporins, and the sensitivity generally is to carbapenems. I have purposely put it down. However, the other drugs that it may be sensitive to are aminoglycosides, fluoroquinolones, piperacillin, tazobactam. How do we decide what to use? Do we have any guidelines telling us what to use? So the September 2020 Infectious Disease Society of America guidelines regarding ESBL state that if it's just a case of cystitis, please avoid using carbapenems. This is just to keep the sensitivity to carbapenems. Otherwise, we will have that group also being resistant. So you can use nitrofurantoin or trimethoprim sulfamethoxazole. Pyelonephritis and complicated UTIs, we have to use carbapenems. Quinolones may be used, trimethoprim sulfamethoxazole may be used. Now here again, they say that if you have started carbapenems and you get your sensitivity and it is sensitive to quinolones, of course, we have to remember that we are treating children where we don't normally use quinolones. Only in special circumstances with parental consent and full guidance, we are allowed to use these. We should change over so that we still maintain the sensitivity to carbapenems or reserve these drugs. Piperacillin, tazobactam, and cefepime are avoided even if sensitive. This is because the in vitro and in vivo sensitivities may not match for these antibiotics. Antibiotic resistance in pediatric urology is on the rise. A minute to sit and think, why is it rising? How are we contributing to it? It is related to excessive use or misuse of antibiotics. Increased use of a single antibiotic class is also known to be associated with it. Ineffective empiric antibiotic therapy. When we are choosing empiric antibiotic therapy for whatever condition, we have to tailor it to our underlying diagnosis or suspected diagnosis. Prophylactic antibiotic use has been associated with increased antibiotic resistance. And local resistance rates and antibiograms are important. How many times are we looking at these? Those of us working in hospitals, the infectious disease committee always from time to time puts up these antibiograms. It's very important to look at these. And for those who are in whose organization these are not available, at least here in UAE, it's in my humble opinion, it will not vary much. I think we should look at the guidelines from the hospitals and see which antibiotics might be useful and use only those. Interestingly, molecular diversity of ESBL producing E. coli from foods of animal origin in human patients was studied. This is a report published in February 2020, and they concluded that foods of animal origin must be regarded as a reservoir of ESBL producing bacteria of clinical relevance. Which might spread through the food chain. So, of course, we have to look at halting this increase and reducing this increase. We have diagnosed and treated a case, even though it was ESBL, and now we have to decide how do we go further from here. So classically, the thinking has been that any case of UTI, we must do imaging studies because we want to rule out the underlying vesicoureteral reflux or any other urological anomalies. Why we wanted to do that? Because it was thought that recurrent urinary tract infections lead to renal scarring. Older studies, the incidence was 15 to 60%. Recent literature states it's more towards 15%. Why the renal scarring is important? Because it would lead to end-stage renal disease, hypertension, end-stage renal disease. and toxemia of pregnancy. These were the complications related to renal scarring. However, in now the literature states that ESRD related to recurrent UTI is to the tune of less than 1%. And VUR leads to scars, or that is congenital hypoplasia or dysplasia, is a theory that needs to be proven. So coming to imaging, this is probably the most controversial among the various guidelines as far as UTI is concerned. Which are the children we will do imaging on, and when will we do it? First of all, it's not indicated in those with first episode of febrile UTI if they have responded promptly. We have assured a follow-up. They have normal voiding pattern and no abdominal lump. According to the American Association of Pediatricians, USG is done in all infants less than 2 years with fever and culture-proven UTI. However, only and only if there is hydronephrosis do we take the further decision about further workup for BUR or UPJ, uretropelvic junction obstruction. Whether we do micturating cystourethrogram, MAC3 scans, or DMSA scans depends on what we find in this. So as a rule, it has been said that for the first episode of UTI, it is probably not indicated to go ahead with a micturating cystourethrogram. Timing of VCOG, earlier it was thought that we have to wait for VCOG. It used to be done more than 6 weeks after an acute infection. However, in certain high-risk groups or groups where we need to find out the presence of VUR, it has been recommended that it can be done early and it is not associated with a great deal of problems. Definitely more aggressive workup is needed in those with urosepsis or those who presented to us with systemic inflammatory response syndrome or those who required ICU admission. Once this AAP guidelines came out, there was a lot of uproar. The guidelines were dissected by all the pediatric nephrologists because for ages, it was a common practice to do imaging as well as to put these children on chronic antibiotic prophylaxis. The RIVER trial in 2011 mentioned that this was a trial for randomized trial for VUR, that AAP guidelines of not routinely obtaining VCOG after first febrile UTI require reconsideration. There was a QT trial that was designed to specifically evaluate renal scarring after UTI. VUR combined with bladder and bowel dysfunction are risk factors for recurrent UTI. And prevention of recurrent UTI requires prophylaxis with antibiotics as well as bladder and bowel dysfunction treatment. So these trials showed that the prophylaxis was superior to placebo in preventing recurrent UTI. Now, why do some children have recurrent UTI and scarring? Now, this is a lot of genetic susceptibility, a lot of genes have been found out that make you predisposed to that. Going through some images, ultrasound showing hydronephrosis, micturating cystourethrogram showing massive reflux in the passive and the micturating phase. This is an oblique image, and this is an image which shows a duplicated system. We may even see other anomalies in these scans. This is a picture showing DMSA scan. This child presented with UTI, found to have right grade 5 VUR, and this is a DMSA study. Now, DMSA study, when you do it in the acute phase after UTI, may be just indicative of reduced uptake, may be indicative of acute pyelonephritis. However, when you do it after a few months, 3 to 6 months, it shows scars. It's more indicative of scars, the reduced uptake that we see in this DMSA. So, will we put these children on prophylaxis or not? What does the literature say? In 2010, there was a Cochrane review, and it looked at the efficacy and harm of long-term antibiotics to prevent recurrent UTI in children. The conclusion was it helps, but benefit is 8%. Number needed to treat was 12 to prevent 1 UTI. Why are we so concerned? Because prophylaxis is a risk factor for antimicrobial resistance, which is on the rise. Children receiving cephalosporins are more likely to have ESBL or MDR uropathogens causing breakthrough UTIs. Urine culture allows tailoring of broad spectrum antibiotics and is recommended to do so. However, this again is pretty controversial there was a 2017 review of 7 randomized control trials was done. The number was 1,427, wherein asymptomatic first febrile UTI with or without VUR, there was no significant influence on prevention of renal scars. Less clear data in those with recurrent UTI. So prophylaxis helps in preventing the second UTI, but does it help in preventing scars? Well, the jury is still out on that. How do we give prophylaxis? We choose the amoxicillin in infants less than 6 months, and in those older than 6 months, it's recommended to use trimethoprim or sulfamethoxazole. Cephalosporins were used in a lot of studies, but of late they have gone out of vogue. And these are given in 1/3 to 1/4 of the normal therapeutic dose. And then the patients are counseled, parents are counseled, and they are monitored regularly for compliance. General question, can UTI be prevented? Is there a parental role? Adequate water intake, cranberry products, which actually it is thought that they reduce the adhesion of the uropathogen to the uroepithelium, are used by many, but there is no hard and fast rule. There is no solid evidence to say that they should be used in each and every case. Probiotics have been suggested by some. Regular voiding, this is very important. Now here comes the whole issue of the bladder bowel dysfunction. Constipation is to be avoided at any cost in these children. The voiding diary has to be maintained in those who come to us with either overactive bladders or lazy bladders, and in those who are not able to, who are using excessive strength or abdominal muscles to facilitate voiding of urine, they have to be evaluated separately. That's a separate topic by itself, but it is important to be addressed. So meticulous genital hygiene, circumcision. I think in the panel this will be discussed. Circumcision definitely helps. However, the number needed to treat again is pretty high, more than 100 to prevent 1 UTI. Touching upon certain special situations like neonatal UTI, prevalence we've already said is higher. There is a male predominance in this age group. These neonates present with non-specific symptoms. So here we really have to look for it. Like one study has shown that 12.2% of neonates who were 2 to 14 days of age with raised indirect bilirubin had UTI, and 6.2% of these were bacteremic. So we should, now the controversy still exists whether in every child whose bilirubin is high, should you be checking, should you not be checking? No harm in ruling it out as a underlying cause. The non-E. coli infections were more frequent in these children. There is a high risk of urosepsis, and fungal UTI is more common. Obviously, these children are immunocompromised, multiple lines being used, and sometimes you may see these kind of fungal balls in them, and the treatment has to be tailored accordingly. Kidney transplant and UTI, again, an immunosuppressed group, please, obviously this will be under the care of pediatric nephrologists. The important thing to remember here is the nature of infection. It may not always be bacterial. There could be opportunistic viral infections, example BK virus, which causes hemorrhagic cystitis, which may even cause urethral stenosis. CMV and adenovirus are also reported. Fungal infections have been reported in this group of children. The important thing is that when we do the PCR for these viruses, it has to be a quantitative PCR and not a qualitative one. The altered anatomy because of the kidney transplant, because it is placed lower down in the abdomen, can predispose to mild hydronephrosis and a mild reflux in these children. What about children who have UTI with urosepsis and neurogenic bladder? Now, in this subgroup, as we have already mentioned, asymptomatic bacteriuria is common. But if they have undergone a surgery where augmented bladders have been used, gastric tissue is used, that contains mucus secreting glandular cells, and it's common to see mucus and blood-tinged urine in their samples. Obviously, combined treatment by medical and surgical specialties is important here. Touching upon some complications of UTI, other than the renal scars and ESRD, are renal abscess, emphysematous pyelonephritis, and xanthogranulomatous pyelonephritis. This is a picture, CT picture showing a renal abscess, and these children may require surgical management along with medical management. Xanthogranulomatous pyelonephritis is a condition which is chronic inflammatory disorder. And it is commonly seen in more in adults than in children, but cases have been described in children. And it is a locally necrotic condition, very difficult to treat, and quite often nephrectomy is the way to go in these children. So it's very important to know about it and to identify it and treat it in time. Emphysematous pyelonephritis is where again it's an acute condition, however a very debilitating and rapidly progressive with gas forming organisms. Classical pictures seen on CT and require prompt treatment. So we've looked at how we will diagnose, how we will treat, whether we will give prophylaxis or not, how we will image, when we will image. And now, finally, where are we? What is on the horizon? What is being done in this subject? What work is being done? Coming back to the first beginning of my talk, where I said that urine collection is important. So we still are struggling with the very first point, and we need some non-invasive methods and devices for urine collection. A lot of research is being done in this area. It is also being seen that automated urine analyzers are used, which will screen these urine samples and tell us whether we need to do the urine culture. And in one study using SediMax, it was seen that 54% of samples do not require urine culture. So these are important. We need sensitive biomarkers, which can tell us whether this child has pyelonephritis. As we know that it is very difficult clinically to sometimes differentiate this. So NGAL is one of them, which is more sensitive, more useful than CRP, PCT, WBC count. There are some others like heparin binding proteins, antimicrobial peptide, and human alpha defensins. Going further, what are we? This is about diagnosis. Then coming to imaging, we always have a bit of a problem when counseling parents and doing the MCUG. So we need some non-invasive methodology. We need some methodology where we reduce the radiation risk of doing an MCUG or DMSA. So non-enhanced MRI is being looked into as a modality for detection of renal scarring. It differentiates an area of acute inflammation from a scar as against DMSA. Now, this is radiation-free. There's no IV required. Takes only 20 minutes to perform. Exciting developments in imaging. Another one being superb microvascular imaging. It's a new USG Doppler technique that enables USG images of low velocity flow. It can detect the direction of urine flow. So obviously, if we have a reverse flow, we are looking at high-grade BUR. Coming back to some interesting data, Kopp et al. In 2013 showed that despite all this talk, 1/3 of children treated for UTI did not even have a urine analysis. And surprisingly, urologists had 50% lower odds of urine culture use among antibiotic-treated UTI episodes compared with other internists or family medicine physicians. So, empiric treatment in high-risk groups, at the very least, should be preceded by urine testing. Selective antibiotic prophylaxis in high-grade VUR and high-grade hydronephrosis with counseling regarding compliance and use of local antibiograms, particularly pediatric-specific data with inpatient and outpatient data, are important. So finally, coming to my last slide, what are some take-home messages? We need to keep high index of suspicion in neonates, infants, those with congenital anomalies of kidney urinary tract, and immunosuppressed children. Urine culture is still the gold standard for diagnosis. There is a paradigm shift in the understanding of causal association between recurrent UTI and renal scarring. Judicious use of appropriate antibiotics is the need of the hour. Restricted and targeted imaging studies are recommended by the recent guidelines. Consult surgical colleagues and plan management in cases of recurrent UTI, especially in those with urological anomalies. Long-term follow-up of those with recurrent UTIs and renal scars is important. Shukran.
Thank you very much, Dr. Kalpana, for the excellent presentation. I would like to request the viewers to stay tuned. We'll have a short video presentation, and after that we will start the question and answer. Dr. Joshi also has joined us, Dr. Diari, Dr. Ayman Jundi also in the panel. So we will have a short video, then we will come for question and answer. So please, over to Mr. Tawfiq.